Hello, everybody. Welcome to Hernia U. I would like to welcome to this session 3 of Fundamentals. It's always a pleasure to have the support of BD in this interesting project, and I hope it's interesting for you. And today we are going to cover the international guidelines on groin hernias. These are my disclosure. And I think international guideline is a new era of hernia surgery. A few years ago, the most important international society on hernia, the European Hernia Society, the Afro-Middle East Hernia Society, Australasian, the American Hernia Society, and the Asia Pacific, together with the International Endo Hernia Society and the European Association for Endoscopic Surgery, these 7 societies get together to develop an important guideline to get together all the information around the world to give recommendations and statements. 50 experts around the world were selected, and all these they established 166 key questions. They end up with 136 statements and 88 recommendations. They used the agreed to instrument, and 3 external reviewers went through the guideline before to be published. Last year, in 2 years ago, in 2018, these international guidelines were published, and a lot of important principles of hernia surgery have been established. And this is the way that the future of surgery in hernia, in groin hernia, is going to be. I'm going to go through the most important topics covered by this hernia, and especially those who are changing our daily practice when we perform hernia surgery. If we analyze this risk factor for development of inguinal hernia in adults, you see that the most important risk factors are heritage, are the presence of a previous contralateral hernia, are more frequent in male gender. Age is an important factor, and also is being determined that abnormal collagen metabolism have some influence in the presence of inguinal hernia. Also, low body mass index is related to hernia, and the previous prostatectomy also is related to the presence of hernias. And I've seen a lot of patients with previous prostatectomy, open, robotic, and laparoscopy, who after this surgery, they develop their hernia. In terms of diagnostic modalities, you can see that the clinical examination alone is the most important way to identify and confirm a hernia in a patient. You don't need to do anything else. Most of our patients come to me and they show me that they have a ultrasound or they have a CT scan, but I tell them that is not needed, that the most important way to identify a hernia is the clinical examination. Of course, if you have doubts, if you have a bad groin swelling, or if you are looking for a possible occult hernia, then is the time to perform ultrasound to identify these hernias. Also, in case you have doubts with the ultrasound, magnetic resonance of a CT scan could be considered for further evaluation. On the other hand, on emergency, clinical examination is also sufficient in most of the cases, but you can need, maybe you might need some additional information, and in those cases, an ultrasound and a CT scan might be necessary to get this information to decide to go to the OR or to decide your way of access, the way of the approach that you're going to use to solve the hernia. In terms of hernia classification, this is what I would like to say is very important. We know that the international scientific language is English, but it's important to have also classification to be able to talk of the same language. And this classification is important. If we classify the hernias using different classification, then we could be talking about different results and ending up to wrong conclusions. So I would say that nowadays, the European hernia classification is the most popular one and is the one recommended in this international guideline. You see, it's easy. You can say that hernias are either lateral, which is an L, medial, which were the previous direct hernia, or femoral hernia. And then this 0, 1, 2, 3 means one is 1 centimeter, 2 centimeter, 3 centimeter that usually you measure with your fingertip. And if you're doing laparoscopy, you measure with 1 centimeter, 2 or 3 centimeter with the tip of your instrument. In terms of treatment for symptomatic of asymptomatic groin hernia, you have to know that in males with asymptomatic or minimal symptomatic hernia, there is a low complication risk, and you can decide not to operate the patient. But you have to have in mind that most of these patients with time will develop symptoms and require a surgery. And there is no doubt that in those symptomatic patients, there is no evidence that is to support the watchful and waiting. And the most convenient decisions for the patient is to perform a surgery to repair the hernia. In terms of the surgical treatment, you have to consider that the role of open non-mesh techniques are just indicated in young females with lateral hernia L1 or L2. And this technique to be performed in these patients is the Schuldeis. So the number of non-mesh repair today are very limited. Only these cases could be considered, and remember that Schuldeis is the technique to be performed. If we consider performing a Liechtenstein technique or a laparoscopic technique, when you decide to go for a mesh technique, now today we can say that laparoscopic technique do not take longer than the Liechtenstein. We can say that at the beginning, there was a lot of voice saying that laparoscopy was related with more time, with more complication, and that was and the need of a general anesthesia. We can say today that there is no more complication of laparoscopy, it doesn't take longer, and even there is no problem to perform general anesthesia. And there is advantage of this laparoscopy because it's been demonstrated that laparoscopic technique have less chronic pain than the open Liechtenstein repair, and there is a faster recovery of the patient who undergo a laparoscopic technique. It's true that there are direct operative costs are higher of laparoscopy, but if you consider the total community cost, taking under consideration the time that the patient is out of work, then the total costs of the procedure decrease. So this is something that you also have to consider, that for the healthcare system, laparoscopy is convenient. So at the end, the most important step forward of this guideline is that the first time that it's been said that in a male patient with a primary unilateral inguinal hernia, laparoscopic technique is suggested. Of course, there is low, the recommendation is low, but still being low, we can say today that even in a primary unilateral hernia, laparoscopy seems to be better than an open Liechtenstein technique. Of course, we have to consider the setting in which we operate this patient. And in this lower resource setting, you have to consider to go for open surgery because you don't have the laparoscopic unit, you don't have the proper instrument. And in those cases, if you have to consider to perform a repair of a hernia, maybe it's better to use an open preperitoneal than a Liechtenstein technique. Let's go for laparoscopy. Let's analyze if it's better to perform a TEP or a TAPP. In the past, there was some voice in favor of the TEP, in favor of the TAPP, but today we can say that there are similar operative time, similar complication, similar pain, and similar recurrence rate with one and the other technique. The choice of one or the other technique should be based on the skills and your school, your education and experience. Nothing else will take you to one side or to the other. It's true that TAPP seems to have a shorter learning curve, but on the other hand, the possibility of having a trocar side hernia. And TEP seems to be a little more difficult to be learned than the TAPP. Regarding Liechtenstein comparing with other implants, we can say today that these other implants, there is no reason to replace the standard flap technique. So Liechtenstein should be performing using a standard flat mesh. And on the other side, regarding Liechtenstein versus open preperitoneal, today we can see that there is some light that shows that open preperitoneal seems to be a little bit better than the Liechtenstein technique. But there is no data, still no data, and we need some research to be done to demonstrate if open preperitoneal is better than the Liechtenstein technique. So we can conclude that laparoscopic technique are better in case that you have the proper skill to perform the technique, if you have the proper instrument, but in case you have to go for open, it seems to be, we need to demonstrate that open preperitoneal are superior than Liechtenstein for the future of this open approach. There are some specific cases in which you need to focus. Females, hernias on female patients are less frequent than in males. And female patients have more femoral hernia than males, but there is no clinical or diagnostic tech that can distinguish between inguinal or femoral hernia to perform the surgery, before to perform the surgery. It is recommended that once you diagnose a hernia in a female patient to go for surgery. Do not go for watch and wait, because if the risks of strangulation in this patient are higher than standard hernias in a male. So it's recommended to operate them, and it's recommended to go for laparoscopic surgery. In this sense, in 2009, when a laparoscopic repair was not yet recommended as the standard technique for hernia for male, it was said at that time already that female should undergo a laparoscopic technique for the repair of the hernia. Regarding female pregnant, in those cases, it is recommended watchful waiting and operate the patient once they deliver the baby. So in those cases, it's recommended in case there is no emergency to operate the patient after pregnancy. What about femoral hernia? If you are able to identify this femoral hernia, then the recommendation is not to do a tissue repair, and in case you have to operate the patient, then it's recommended to perform it by laparoscopy. What about recurrent hernia? We can say today that open preperitoneal repair is the technique that is superior to another Liechtenstein in an open anterior hernia. So that means that the patient comes to you with a Liechtenstein and you're not able to do a laparoscopy, you should do an open preperitoneal. But if you have a recurrence after a Liechtenstein, the first choice will be to do a laparoscopy. In case you have a recurrence coming from a posterior repair, either by laparoscopy or by open approach, then the anterior repair is recommended. So go posterior if you have an anterior recurrence, and go anterior if you have a recurrence coming from a posterior approach. In emergency, you're going to find three settings. One is a clean field. In those cases, mesh repair is suggested. If you find a clean or even a clean contaminated field, recommendation in emergency is to use a monofilament large pore polypropylene mesh, and the reason is because it seems to tolerate better an infection. But in case you find a contaminated or dirty surgical field, no mesh is recommended. Some of the doubts come when you are going to operate a unilateral repair, and you wonder if you should perform a contralateral repair, since it is one of the risk factors of developing a hernia. So in those patients who undergo a unilateral hernia, there is a chance of developing a contralateral hernia. So the question, if you're doing laparoscopic repair, what should you do? Because if you're doing open, it's clear that you just repair one side and you don't have to repair the other side if you don't find a hernia. But if you're doing a TEP, there is no recommendation to explore the contralateral side, because if you explore the contralateral side, you are going to create a weakness area, and also you are going to create fibrous tissue that is going to give you some difficult times if you have to repair the hernia in the future. For that reason, when performing a TEP, do not explode the contralateral side. If you're doing a TIPP, then you have to inform the patient, because if you find a hernia in the other side, then the recommendation is to repair the contralateral side. So for that reason, it's important to have a prior informed consent of the patient in case you find a contralateral hernia. Day surgery is recommended in most of the hernias, and even performing by laparoscopy. You can perform a laparoscopic approach with general anesthesia under the concept of day surgery. In terms of anesthesia, you have to consider that general or local are the techniques suggested over regional anesthesia in patients 65 and older. And the reason is because these patients under regional anesthesia have the chance to have more medical complications like myocardial infarction, pneumonia, or thromboembolism. For that reason, we prefer to perform general or local anesthesia in most of our patients. Regarding antibiotic prophylaxis, I will say that there is an increased risk of having an infection in open approach in bilateral and recurrent hernia. But the recommendation will be in open surgery to use antibiotic only in high-risk patients, while in laparoscopic, any patient at any risk is not recommended to perform antibiotic prophylaxis. Regarding physical activity after surgery, their recommendation is there is no restrictions. Patients can come back to normal activity as soon as possible, as soon as they feel comfortable. But there is no restriction to physical activity after this surgery, and it doesn't matter what technique they undergo. Regarding the technique, a single perfect mesh, I have to say that it doesn't exist when we talk about meshes. And if you analyze flat mesh or other alternative, we can say that the recurrent rate of all these 3D meshes like plug, PHS are not superior to the recurrence rate, are similar to the Lichtenstein's technique. And there is some studies that demonstrate that there are more complications and pain related to these 3D meshes than a standard flat mesh, having the same rate of recurrence. So today we can say that three-dimensional implants like plug and patch and bilayer meshes are not recommended to perform inguinal hernia repair. On the other hand, if you analyze self-gripping meshes, we can say today that there is no benefit in terms of pain and in terms of recurrence. And the only thing that is being observed that maybe there is a decrease on operative time, but this is not, this doesn't justify the cost of these new meshes. So basically, the use of other implants more than standard flat meshes is currently not recommended. What about lightweight and heavyweight mesh? So these terms of lightweight, weight, or heavyweight mesh are not recommended, and most of the people talk about the pore, the large pore versus small pore, because the amount of material is not it's not related to pain or not relating to the integration and the ingrowth of the mesh. It seems like the pore are the most important factor that is related to the incorporation of the mesh. The benefits of using these lightweight meshes, the so-called lightweight meshes in open surgery, it seems that there is in short term, there is a slight benefit in terms of less convalescence and less feeling, less pain after surgery. But on the other hand, when we analyze the use of this lightweight mesh for TEP and TAPP, there is no relevant difference. So there is no reason to use them. Pore size, it seems to be the most logical way to classify the meshes, but it's not clear enough the role of these meshes, lightweight, large pore, in hernia surgery. In the meantime, we recommend medium large pore, monofilament, flat mesh for hernia surgery, because even there is no clear evidence, seems to have a less feeling sensation at the groin with these meshes than with the heavyweight small meshes. And for sure, flat meshes are superior to these 3D meshes that have the same rate of recurrence, but they have more possibility of having chronic pain. And when I talk about 3D meshes, what I mean is plug, PHS, double ligament meshes, and this type of device used in open surgery. Regarding the concept of mesh rejection, we have to say that there is no evidence to say that there is immunologically based rejection. Most of the time, when there is this rejection, is because there is a chronic infection. So people still use this word of rejection, but we have to say that in most of the case is a chronic infection. What about fixation of the mesh? When we talk about open repair, it seems that glue is reduced pain. So we can say that a traumatic mesh fixation is superior than traumatic fixation with either staplers or stitches. So the trend today will be to avoid fixation. In laparoscopy is even more clear about that. In TEP repair, it's not necessary to fix the mesh, and it's been demonstrated that a traumatic mesh fixation reduces pain. The only cases in which fixation could be considered is in large direct hernia, which is M3, those medial 3 centimeter size hernia. In those cases, it's been recommended to use fixation. Which are the other aspects that you should consider? Regarding seroma, I will say that inverting and fixing the transversal fascia during laparoscopy seems to reduce seroma, especially in large direct hernia. Some people, what they do is they fix the transversal fascia with a tacker to the Cooper ligament. I do prefer to use an endoloop to plicate this transversal fascia, and it seems to have a relation with a reduction of seroma. No drain is recommended. So it's been demonstrated that the use of drain is not going to reduce the amount of seroma. During female during surgery for to repair hernia in female patient, is being a lot of discussion about the need of division the round ligament, even in open or laparoscopic repair. We can say that it seems to be easy, the technique, when you transect the round ligament by laparoscopy. But there is an important issue related to that. There is no complications related to dividing the round ligament. But if you're going to divide it, it seems to be more important to divide it proximal to the peritoneum, because there are less possibility of having an injury of the genital branch of the nerve. So if you transect this round ligament far from the peritoneum, then you can have chronic pain. And talking about chronic pain, in terms of preventing pain, nerve have been discussed if you should dissect and look for them. And I have to say that this guideline tells you that it's not recommended to look for the nerve. And also it's not recommended to do a prophylactic nerve resection, because you are not going to reduce the pain incidence. Sac, if you invaginate the sac, it seems to be associated with a reduction of pain. But on the other hand, if you don't transect the sac, it seems to be more related to recurrence. So it seems that invagination related to less pain, but with more recurrence. Fixation. Don't fix the mesh to the bone, to the pubic bone. So if you have to fix it, try to look for other areas to avoid fixation to painful areas. And regarding the spermatic cord, it's important to minimize the surgical trauma to the spermatic cord to avoid the presence of pain at the testicle. So it's important to know that we still have to work. It seems that all the experts have excellent results, but if you go to the literature and you go and you are an expert in hernia, you still see a lot of patients with chronic pain. And the number goes as high up to 10 to 12%. And at the same time, the range of recurrence rate seems to be up to 10 to 15%. So that means that even though we think that we have excellent results, there is a lot to be done, and we can improve our results. So I will say that the best operative technique is the one that you are an expert on. You have to train yourself, it's important, but we have to look for a technique with a low incidence of complication, easy to learn, with fast recovery, reproducible, and cost effective. Thank you very much.